Welcome back, everybody, from the lunch break. I want to orient folks as to what we're going to be doing for the next hour or so. We are going to be facilitating discussion amongst the TPSAC members, looking at questions 1 and 2 posed to us by FDA CTP. I'm going to try to shoot for dividing our time roughly up into thirds, where we're going to focus on question 1 first, question 2, and then we'll wrap up the discussion by having everyone at the table, with the exception of FDA, making their own final comment about the Swedish Match Mrtp renewal application. Then we'll have a break, and then we'll have another presentation from FDA that's not specific to Swedish Match, and then we'll have additional discussion after that. And so with that, if we can pull up the first question. So question 1, FDA reviewed the literature and the applicant's data and conducted internal analyses of the applicant's data to describe characteristics of people who use snus, patterns of tobacco use among people who use general snus, and transitions from combustible cigarette smoking to exclusive use of general snus. And so we're going to discuss the use behaviors of these modified risk tobacco products and any implications they might have. We will try our best to call on you in the order that people raise their hands. And so if anyone would like to start, Scout?
All right. First of all, I guess I'd like to go on the record saying that I'm disappointed in one aspect of this meeting, and that's the fact that we are being given quote-unquote evidence at a scientific meeting that honestly wouldn't pass the standards of any publication or training that we get at a professional organization, because I just spent a lot of time during the beginning of the meeting trying to understand how many of the people for the public comments out of the 25 we were given in advance were actually connected with the tobacco industry. And as I can understand, only 2 out of the 25 public comments clearly had no connection with the tobacco industry. And everybody who did not claim they had a connection, we have a long history of the tobacco industry hiding their connections with these organizations. And then we even have, the number of people who spoke publicly who did fun things like, Reason Foundation saying that I had to look at their magazine in order to find out that they have $14 million in tobacco industry contributions just in the last year, which is more work for us. And other people just saying that it's above their pay grade, whether or not they're paid by the tobacco industry. So I would just like to say that I think we really want this to be a scientific meeting, and we want it to be accessible to people. We have a problem right now. We talk about the regulatory barriers that the industry is facing. I also think we have a problem that the public health industry is facing, and even being able to respond appropriately to these things and suss out who is actually representing commercial interests and thus giving us a sales pitch versus who is actually representing an independent interest and is not funded to have an opinion one way or the other. So not only am I concerned about how hard it is to decipher that as someone representing the general public here, but also it's a concern that only 2 of the 25 comments in advance appeared to not be represented by industry. So I would like to really ask FDA if we can have a better process for disclosing how much of the information presented to the Scientific Advisory Committee is sales information and has a significant conflict of interest and thus would not be allowable in any CE or CME presentation or any publication without that being disclosed. And the optional part of the disclosure is something that clearly people are not taking advantage of. The only people who are the ones who don't have conflict. So that's just a point I want to point out in advance. I think we've got some real barriers to the community that does not have a conflict of interest in being able to navigate this process, put in comments related to it, and decipher whether there are conflicts of interest on the existing comments. With that said, as far as I can understand, if we are listening to the people who do not have conflicts of interest, out of the 5 people that I could discern did not have conflicts of interest, 4 of them were clearly very much against this proposal. The 5th was very clearly pointing out that there were enough gaps in the data that was a position that was of such a situation that they could not take a position because of the significance of the gaps in the data. And so we seem to have near uniformity from the non-conflicted points of interest on what a decision should be here, and I encourage us to take that into account as a scientific body. If I look at the actual data and the strength of the data and the research, I would have to say that I'm also not sure if we could pass any kind of an NIH standard to get this funded if we had presented similar data to NIH about a project that we were interested in. Because if you first talk about the fact that it is a convenience sample, that there was no effort made to even compare it with the full probability sample we had to even match the demographics from PATH to adjust or provide weighting to the convenience respondents so they more accurately represented the real population being affected by this issue, that's a significant challenge in the data. The fact that we have such a high rate of attrition is also a significant challenge in the convenience sample. I'm particularly concerned that we have a high rate of attrition in the youth population, which we are particularly concerned about, and also with low SES. The idea that by wave 4 we had it was predominantly higher SES people, which to my understanding of smokeless tobacco and snus use is very discordant with the general population using snus, makes me very suspicious of the wave 4 information. And then you add in the fact that what's being asked for as a continuation of this warning is, again, applying only to people who are solely using snus and at 0 levels of, combustible cigarette use. And by what I see from the data, that's only a quarter of the population that are using snus right now. So as I understand, we're currently being asked to continue warning a quarter of the population about something that's relevant to them, and then putting out a warning that is not relevant to the other 3/4 of the population that snus is approaching, which also, again, makes it a concern. You add in the fact that we have from industry documents that it's not appealing to youth, there's no evidence thereof, things like that. And then you have from the non-conflicted presenters information like we have a substantive increase in the number of youth between 2022 and 2023 on the National Youth Tobacco Survey reporting snus use. And from one of our presenters talking about the fact that that's 330,000 youth using snus right now. That appears to directly contradict the information given by the industry related to appealing to youth. And then you also talk about the fact that while there is snus declines in a lot of the data presented, we also see from past data that there's snus use increase instead. So you add all of these things together, and I cannot exactly see where we find substantive information to support the continuation of this warning, which would only, again, even apply to a quarter of the users and not actually apply to 3/4 of the users. Back.
Donna?
Thank you. Yeah, and I echo Scout's concerns. And as an associate editor for the American Thoracic Society, the studies would not be published. They wouldn't even be, accepted to go out to reviewers. And so I have a lot of concerns about the quality of the data that we're looking at. And I'm wondering if there's some way for FDA to sponsor good studies that will answer the questions that we're interested in. Thank you.
Lucy?
Let me step back and kind of lay out a little bit of framework through which we can look at this. I was trying to understand what are the criteria for renewal, and in different and what the study was supposed to do. And in different places, it's listed differently. So I went back, and in the presentation earlier, they talked about the draft guidance to the industry, which was never finalized. I went back to the Tobacco Control Act itself. And in the Act, it states that the applicant, once they receive the order, they need to determine the impact of the order issuance, of the order in the Mrtp claim on consumer perception, behavior, and health. So this is the mandated thing where it's like you need to assess the impact the Mrtp claim has on consumer behavior, including uptake, dual use, and complete switching. Instead, the study, and in the study documents, again, some of which were really heavily redacted, and I feel like as members of TPSAC, we should have received them as early as they were submitted and non-redacted, because we need to see those original tables, and none of the data were there except in big summaries, which then were summarized as like making claims that the data couldn't support. But the study objectives were like, how do general snus users use tobacco and nicotine products? This is very different from what impact does the order have on behavior. So in that sense, I think it would be good to have for the FDA to clearly specify what are the criteria based on which we will evaluate the evidence. Right now, the study basically, it's been presented as we are showing the evidence of absence of negative effect and evidence of good effect, which is not the case. What we're seeing is absence of evidence.
So I do want to say, take a moment and jump in myself with my own comment about this. And so I do think that, and I'm hearing other folks say it as well, the post-market surveillance study, there was quite a bit of disappointment in the execution of the post-market surveillance study. As a survey methodologist myself, I was disappointed to see how that was executed. That being said, I do want to remind folks that that post-market surveillance study plan was signed off on FDA. And so there might be recommendations that come out of here about strengthening the quality of post-market surveillance studies. And I think that that's an important thing for us to remember, is that this was also a plan that was signed off on, and that there are some answers we're not seeing is a function of the way that that study was designed, and that there's shared responsibility in the sign-off of that particular post-market surveillance study. So,
I agree with Donna's suggestion that it seems worthwhile in order to make the determination of APPH to do additional analyses of a data set that might be able to more rigorously answer the question. And so the U.S. PATH study with now 7 waves would provide a sufficient data source in order to, in detail, look at transitions in snus use and subsequent transitions in use of other tobacco products. And what would be of interest is cessation of combusted tobacco products, dual use, escalation or declines in the frequency of tobacco use overall, and then also as a comparator, another product that is non-combusted, what are the switching rates for that product to provide a gauge overall of the impact. And then relatedly, one thing that hasn't come up yet is use in the young adult population, and it would be useful to look in the most recent waves of PATH about that use. According to the data that I'm aware of, the last published analysis of PATH, or one of, I guess, the few, 10% of young adults age 18 to 24 had ever used snus back in 2013, 2014. So looking at those estimates currently would be of use to the decision. And then finally, in just thinking about youth uptake, I think the presentations today focused on current use, which was low, less than 1%, I believe, of snus use. But current use may not be the most sensitive indicator of risk of uptake of regular and potentially harmful tobacco product use patterns, given that teens, may have a slow escalation that crosses years. And so, of note, I think the most recent NYTS reported that there was 3% smokeless tobacco ever use in their sample of high school and middle school students, but I don't believe the snus category was taken apart. So that seems like an additional analysis that could be done to address the question as to whether impact on switching versus impact on youth uptake and potential other beneficial or harmful consequences like dual use.
Donna?
Thanks. Just a follow-up to that. Is this something that CDC could do, as part of their NMWR reports?
Ben's raising his hand with a response or an answer or clarification.
Yeah, I just did want to chime in. In the FDA backgrounder, we do have estimates of snus use among adults and among kids from the past study and from NYTS, but keep in mind that's the whole category of snus products. We're talking about 8 specific products that have been authorized with Mrtp. So I think it's really important to, as you guys are deliberating, to think about, well, one, I'll say it would be very helpful for us to hear from you all about recommendations for the ways to, better ways to design post-market surveillance and studies. But I think we have to be really cognizant of the fact that we're talking about a very small number of users, right? I'm not sure it's really feasible to do a probability-based sample to discover the few thousand users that exist out there. So I think to FDA it was pretty logical to kind of recruit at the point of purchase. I mean, I get that presents some challenges in interpretation, and we'd really just love to hear your perspective on what, this evidence that's been presented can tell us or can't tell us. I think we're getting a sense from the initial discussion, but I do think that's kind of just an important part of this to consider, and so for example, as large as the past study is, it's not really designed in a way to be able to estimate the impact of, a few particular sub-brands of a product that's not widely used. Also note that the, that number 300,000 was mentioned, but I'm pretty sure that was referring to smokeless tobacco product use as a category, not snus as a subcategory. So we do have those estimates in the backgrounder. Also, just note that the APPA standard is actually the standard for the pre-market tobacco product application, appropriate for the protection of public health. The standard for authorization of a risk modification order it also talks about population health, but it's it's that language around significantly reducing the harm to individuals as well as benefiting the population as a whole. They're still both population health standards, but I just wanted to clarify that. So I'll just say that it just would be really helpful for us to hear, your all's perspective on what do you feel like are the takeaways from these studies? Are there, certain things that are we can be more confident in terms of what it's telling us? Are there certain things that we can be less confident in? Just sort of having that discussion would be helpful. And then, of course, as folks are mentioning, any thoughts about how studies can be designed in a better way moving forward? We'd also, of course, love to hear that.
Thanks, Ben. So a couple thoughts and reactions to what you said. So first, with regards to designing studies, I know others take objection to the fact that it was a convenience sample. Really, it was a cohort that was recruiting specifically general snus users. And I think that, as a starting point, was appropriate because we do have PATH and NYTS as population surveillance to help identify if there is unexpected uptick in behavior for the product category as a whole, and then specifically if there's uptake of the product category, then you could look at the brands that are being utilized if there's high uptake. So I think the data sources are complementary and they fill gaps with each other. And to me, it was more the measurement in the instrumentation of the post-market surveillance study, and then the attrition. The attrition is a huge, huge problem because you're losing people. And so efforts at, should there have been, for example, replenishment after that first major drop-off might be some of the things that FDA thinks moving forward for additional applicants that have MRTPs and need to continue to do post-market surveillance studies. I also want to just remind folks that, snus is a subcategory of smokeless, and general snus is the product we're talking about, and I think we need to be careful in not attributing things we might be seeing in a product category overall, specifically to one brand, when in fact, Camel Snus is the #1 selling snus product on the market today. It's not general snus at all, and it actually might be lower than Grizzly Snus and some of the other brands as well. So I think we just have to be careful, because when we talk about PMTAs and MRTPs, we're talking about a specific product and a specific brand, and we can draw inferences from larger categories, but I think also need to be thoughtful with those particular inferences. Mignon, on the phone?
Yes, I'm here. Thank you so much. I appreciate it. I just wanted to add my 2 cents in here. I do agree with my colleagues about the rigor of the post-market surveillance of the study. In particular, I agree that the instrument and the measures were problematic, and implementation was also concerning. But when we consider this application as a mechanism, watching the presentation from the applicants, excuse me, I consistently honed in on a desire to communicate that this product can help to facilitate switching from other combustible cigarettes or transition from combustible cigarettes, or just putting full stop. And this is, herein lies a little bit of a problem. And I don't know that it's as much an issue with the applicant, or as much of an issue with sort of how we're operationalizing these things within the FDA, which I'll get to in a second. But the data is presented by the applicant. It did not adequately address the dual use of combustible tobacco products or other non-combustible tobacco products, such as electronic cigarettes. And we know that individuals that maybe use combustible tobacco products combustible cigarettes and transition off of those, they may, in effort to quit smoking or quit using those products, they may use multiple products, right, in the sort of over the life course as they're trying to make these transitions. And we just don't capture any of that in these data. And the notion of dual use or co-use is particularly concerning if we're talking about not just combustible cigarettes, but other non-combustible tobacco products. I'm thinking in terms of e-cigarettes, actually, because we would see a quick transition over from combustible cigarettes to e-cigarettes before we'd see something like snus. But I'm concerned that any sort of dual use or co-use increases a variety of health risks, and it potentially exacerbates underlying health conditions that we already expect, as the evidence already shows, from individuals who are currently using or have used combustible cigarettes in the past. So I'm just not seeing a lot of compelling evidence that at this moment, it's not to say that it cannot be produced in the future, that we can actually issue a renewal, and this is, with the data that's been presented. And there's something else that was a little bit problematic for me, and perhaps it's not as big of a concern for my colleagues, but I'm thinking about the primary form of data collection being an online survey, which I have no problems with. I too am a survey methodologist, and I understand and value them, but I'm actually concerned about the lack of rigor, given that there's like no biochemical verification in terms of understanding other products that may be used along the way. So it's kind of hard to assess or ascertain the potential use behaviors or the health risks fully if we don't have that additional information. And considering the fact that the sample is so small, you should be able to somehow conduct a study of this nature. So yeah, that's what I have to say for now. But I do think that there's merit in having future discussions about strengthening the rigor and the quality of post-market studies, particularly in this one, in this case. Thank you.
Risa?
Thank you. So putting the approach, the questions and the approach aside, I thought the study on the slide on the switching was compelling at first. And then if you look at the numbers, only 16.7% actually switched completely, whereas 33%-ish went to some day, and 50% only reduced their cigarettes per day. So, you know, that's on the order of 70% of that those respondents who did not achieve any reduced adverse health effect. And so I'm wondering if that's the criteria, do we really have a modified risk product in comparison to just completely switching from cigarettes to no cigarettes based on any other cessation method?
Nancy?
So I'm of several minds about this, because I accept that the quality of the post-market survey was not what we would hope for. I mean, I think we're asking for a level of specificity in answering a question that is just not, I'm not sure it's achievable. I suppose it's achievable with enough money and enough sample, but that's asking a lot for each single product, and it would make more sense if there was something for smokeless tobacco products that you know, if we had more like a standard for types of products as opposed to specific brands. Now, I realize that's not how the law is written, so we probably can't do it that way, but that would seem to be a lot more sensible. I agree with the statements here that the post-market survey design, I think, was reasonable the way it was done and the way it was conducted. I do think that the results, that the analysis could be better, and I'm wondering if FDA would have any capacity to, after hearing all of this, maybe go back to the data that they have and at least try to do some more sophisticated analyses of especially the loss to follow-up people. So I think the question is just, what is the level of evidence that we need in a regulatory setting as opposed to more of a basic find the science setting? And I just wonder, I don't want us to hold this to too high a standard, and I'm sorry, I wonder if, I don't want us to have such a high standard. We need to figure out what the appropriate standard is for the level of evidence that we are asking for. And I think maybe that wasn't entirely, you know, I think it maybe wasn't entirely clear. I think that, I'm not saying that we should say, okay, fine, it's okay, but I think that we should, maybe the disagreements that we're having with the results we're hearing is because of that.
So, and perhaps FDA can clarify instead of having me paraphrase. But with regards to making a decision on an MRTP or an MRTP renewal, there are several pieces of the puzzle that must be considered, including, you know, is the modified risk claim accurate based on the health risk of the particular product? And we're not spending time here today discussing that piece, because my takeaway from FDA reviewing the evidence, reviewing the updated literature, is that with regards to the specific product itself, it is a lower risk product, and no new science has been introduced to change that particular assumption. We're not talking about that because we've not been asked to discuss that piece. So there's other components to it, and that has to also do with how consumers perceive and understand the products, which is relevant to question 2. And then the last piece is, what are the potential benefits and harms to the population as a whole, which is where question 1 and the behavior piece kind of comes in. Did I get that right? I see Jennifer's kind of nodding, and Ben turned his mic on.
Yes, I think that's fair. You know, I mean, Dr. Popova talked about the post-market surveillance requirements, and the rest of that sentence, it talks about, you know, why they're being conducted, include to review the accuracy of the determinations upon which the order was based, right? So it's like we're continually assessing. There's new information here. What you know, do the determinations that were made prior, do they still hold, or has something changed that would alter that weighing? So I think you've captured it.
Yes, I'm actually quite concerned that we are not discussing the issue of health effects here, and that probably the data from 2014 are still seen on their face value. I still think there are some concerns about health effects that were discovered recently, as I mentioned, the mucosal lesions and the link of snus with diabetes. So I think FDA would be well advised to look into these and develop approaches to monitor, right? It cannot be expected to be monitored right now, but maybe through PATH and other approaches, this can be monitored. I wanted to stress that I still have the feeling as if both the manufacturer and FDA see these products as if they were cigarettes from that perspective. They are looking at lung cancer, nitrosamines and other constituents, but these products have constituents that are not present in cigarettes with their own toxicological properties, including flavors such as the Wintergreen flavor, methylsalicylate, or also they have like synthetic sweeteners in them like ACE-K, where FDA has certain recommended values that people should not exceed, and it's been shown in both cases that smokeless products users in some scenarios actually exceed the intake of these substances and the FDA recommended values. Coming back to the actual data, if we take them at face value and the questions, I think there's a big discrepancy between how people understand the risk. I mean, in these questionnaires, we see that over the 4 waves of PATH that were analyzed here, 80% of users on average say that, yeah, they should not smoke any cigarette at all to have a benefit from using these products. However, then in what we see in the actual behavior, it's less than 20% of users who exclusively use general snus, or even less, right? So there's a huge discrepancy about what people understand, or in fact, they may not actually understand this after all, and what actually then the use behavior is. And the third thing I'm concerned about, we just discussed that. The amount of products sold here is minimal in the United States. If you compare that to ZYN, for example, there's 40 to 50 times more cans sold than general snus. I mean, is there, in fact, a benefit for the whole population with these small sales numbers? That's really hard to say, right? So I'm just concerned we're discussing here, spending a lot of time discussing a product that has a minimal market share. So thank you.
Maria?
If I step back and think about really what is the purpose of the Mrtp claim, is really to provide truthful, accurate information to adult smokers so that they can make informed choice. But I think it's very hard to say that, we have way more ways to do what they will do with the claim or with the information they receive. And when we are looking at the population, there are many multiple factors which people will take into account to change behavior. One of them can be motivation, one of them can be they are concerned about their health, and therefore I don't think that the claim alone can do all those kind of things. It can provide the information which can help them to change the choice. And when we talk about this study with all the limitations, I still see that, there were several smokers who were able to completely switch from smoking to snus. We've heard about, it's a very small number of people in a large scale of adult tobacco consumers, but I think we should be thinking about like every
live counts and can be potentially influenced by having the product available for them, having the information about reduced risk potential. And therefore, I think what we need to be really focusing on having more products in the marketplace that consumers can choose from, which they fit their preferences and can be satisfying. So whether the dropout rate were because they didn't like the product or, tobacco landscape was changing significantly. So we don't know really what happened to those people. But I think for those who stayed, who we've seen from the attrition analysis, those people were committed to smokeless product, snus product. They were willing to or trying to quit smoking. For them, this product worked. So I think we have to be balanced between whether we are expecting 100% change among all the tobacco consumers who potentially could see the claim, or really on looking for those that the product really was working for.
Olivia?
So I think with respect to the youth issue, I think it's actually reassuring to see, at least from the population level data, that it hasn't really changed over this time period, which is, I think, consistent with what we would want to see in this situation. From the consumer study, I think that there are definite issues with the study design, as have been mentioned, but at least among those that did participate who appear to be true users of this product, there is at least some evidence that for some people, it did seem to help them move along in the right direction. So is there some benefit to some people? Perhaps yes. I don't know that we know from a population level impact that it's a huge impact, but it does seem to help some people. I think one issue I have with the study in general is that we don't know the extent to which any of this is actually related to exposure to the claim. So that's a challenge. And with that in mind, and what we've heard about how it was quite limited, I think that's something that we need to think about. Some of these movements could actually be a conservative estimate of what would have happened if they had more information.
I'm going to call on Donna in a second, but I want to also open the floor up to folks that we are going to continue discussion, but I'm also putting question 2 up there for folks if we can. Feel free to still comment on question 1, but start bringing your discussion for question 2 in.
Thank you. I agree that every time we can help anyone who uses combustible cigarettes to stop is a success. As a clinician, every time I have one patient who'll stop, it makes my day. I don't know that we can say with certainty that the use of snus is what helped those people stop smoking. A certain percentage of people stop smoking every year. Is this above that baseline? We don't know because there was no comparator. I'm not saying it's not true, but I don't know that we can say with confidence that it is. Anyone want to start discussions off on question 2? Consumer understanding and perceptions? Oh, I'm sorry. Rita.
I just want to make one comment about the applicant in the presentation claimed that the advertising wasn't meeting the unintended audience, and meaning youth, but yet I have a question around why do we have the same percentage of youth users of snus than we do have adults? So it's like 0.5%, 0.5 to 0.7% of youth, and 0.4 to 0.8% of adults. To me, it seems like we have the same percentage of youth and adults using the product, and if that was the case, how are we claiming that we're not reaching the youth in the advertisement?
I'm not going to answer for the applicant,
right.
But
yeah,
when you're looking at snus use in general, there are multiple brands that are on the market today, so we don't know specifically which one. And then prevalence for youth and adults is often calculated differently, where for youth it's any use in the past 30 days, and that includes experimentation. So just some context on measurement.
I was just wondering how, are we initiating snus in youth, and then they're continuing on into adulthood? Because that really wasn't addressed, but I don't see how they didn't state that it's starting in adulthood, and yet we do have prevalence in youth at the same rate as we do in adulthood. So I'm assuming that they're starting in the youth and they're continuing on.
Lucy.
Well, let's talk about the understanding and perceptions. Again, as I mentioned, the TSA Tobacco Control Act specifies that it should be determined the impact of the order issuance, which means the claim, on consumer perceptions. In this study, what it tells us is this sample of heavy users, what do they think? This is not in any way can be connected to the impact of the claim on their perception. We don't even know if they saw that, how much they've seen it, if they were exposed or not. This could be their pre-existing belief. It could be an effect of the claim. We do not know. So in that sense, none of the information presented answers the question of how the effect of the claim on the consumers. What we do know, and this is the same information as before, is there's some misperceptions, there's among the users, and this has always been the case. If you use the product, generally you perceive it to be less harmful. So it's nothing changed. So we're kind of like back where we were before, but no new information that can allow us to make any claims on how consumers perceive this can be drawn from this data.
Scout.
Regarding consumer perception, I'm also very concerned, I think, that the potential of where this is put and the placement and the potential halo effects, as we heard from one of our folks giving testimony that did not have a conflict of interest, or earlier giving public comment, that when you see a warning like this, there is some evidence showing that youth in particular then extrapolate that warning to the full product class and apply it across the broad product class. So there's real concern I have that while their research was attempting to answer this question in a very narrow capacity, there really may be placement effects that have a significant impact. As well, we've heard several times, and we can see it ourselves going on the internet, that there is this co-marketing of this alongside Zyn, and considering that has had a rampant runaway effect with youth these days. All you have to do is visit any college campus, and you'll understand that herd of horses has left the barn, and we're dealing with a whole new level of addiction that we're going to have to try and sweep up after the fact with too few resources. That this co-marketing and the potential impact of having this halo effect and the co-marketing in place could be potentially very dangerous. As well, just as a broader thing, I would also like to say that considering snus is the sole category of tobacco products that I know of that has a particularly targeted marketing campaign for the queer communities, it's particularly disappointing to think that the queer information was willfully not collected in any of the data provided here.
I do want to add one comment on the co-marketing and broadly speaking to the public health community for not actively engaging more in the open public comment period, because we heard the views of researchers at one institution. And the co-marketing that was pointed at in the open comment letter, the public comment letter, pointed to the fact that the retailer site Northerner, which sells a variety of smokeless tobacco products, was promoting both Zyn and General Snus. But Northerner also sells Free, Lucy, Camel Snus. It sells a variety of products. And so to say that the company is co-marketing when a third-party online retailer is doing co-promotions, they're not the same thing. I mean, that there might be co-marketing.
I'm not sure that alleviates the concerns of what the impact might be about having this warning and halo effect if co-marketing is occurring by any entity.
Annette.
So I want to build on what you're saying, Dr. Scout, because as I'm sitting here and I'm rereading the messaging, and I completely agree with all of my colleagues here, the label states General Snus. And I heard Lucy just say, generally perceived as less harmful. So as we think about the word general, I'm not pointing fingers, but if something is marketed as General Snus and has an MRTP claim on it, amidst a Powerwall or amidst other marketing, this halo effect is potentially likely to happen.
Lisa.
Yeah, so I definitely agree with what I'm hearing here. I do want to point out that as we discuss the dangers of the halo effect and assuming that the Mrtp claims can be extrapolated to all snus products or all products in a certain category, I do want to point out that the health effects data is all snus products. And so just when we're discussing that, just keep in mind how important the distinction is.
I was just bringing up, isn't our particular co-marketing concerned about actually not even a snus product,
right?
But, you know.
No, I think that's a separate question, yeah.
Ben.
Thanks. Just wanted to comment on a few things. One, I just wanted to clarify that these products all have required health warnings that are the same health warnings that are on smokeless products, but what we're talking about here is a claim that's related to modified risk. So it's a claim of reduced risk. It's not, that's not a warning. They have separate warnings. And I guess it would be helpful for FDA to hear the committee's perspective on the question of understanding, I guess in the context of, you know, what the evidence is telling us around whether consumers, the consumers who the company is communicating they're targeting, adult smokers or adult tobacco users, whether the understanding appears to be correct, or there's inaccuracies, or are there any concerns about misunderstanding. So I think it would be helpful to just have further discussion there. I think it's also, I know that, you know, there's been a few comments about the halo effect, and it would be helpful to sort of think about that in the context of what the applicant communicated in terms of how they're actually presently marketing the modified risk claim. Would that still hold? You know, is that more of a concern if the claim is being marketed on the product, you know, directly next to another product versus what we were hearing, which is sort of a much more kind of controlled, age-gated communication. So yeah, just it'll be helpful to kind of hear more of that. Based on what we've got in terms of the understanding data, is it in the direction we want to see it? Are there concerns that have arisen, or something in the middle?
Aren't they asking for an expansion of it as well? Beyond the age-gated?
Yes, I mean, that's what they've talked about. But I think I'm talking about in the context of what the post-market data are telling us, and how the company is communicated that they've marketed it to date. Just sort of having that context, I think, would be useful.
Donna?
In terms of the health warnings, one thing I didn't see was the increased risk for heart attacks and strokes, which might have more impact, especially on older users, than gum disease.
Adam?
Yeah, I mean, in relation to these questions, nuances like where the Mrtp claim is placed on an advertisement, and then how do those affect perceptions, I'm not sure, but it could have important effects, either, you know, to enhance accurate perceptions or lead to misperceptions or halo effects. For instance, one of the things I noted when reviewing some of the example marketing is the word lower risk was bolded, and that was the only bold statement. And so I wondered whether that type of presentation of the information could lead people to focus in on lower risk and not really read the rest of the statement as clearly. So whether there could be requirements related to how the information is presented. And one other point related to the I guess the website and the procedure that people need to be 21 and a existing nicotine tobacco product user. I was, I applied the company for having some protections in place. I was confused as to why the gate included any nicotine and tobacco. If their target audience, wouldn't it be people who smoke cigarettes? Or would it also include people who use other tobacco products, including e-cigarettes, and nicotine pouches, and of course the other smokeless?
Olivia.
I think going back to the perception data that was shared, at least in my read, I think it does show us some understanding of the direction that we would hope, at least among the users. Most answered the relative risk question correctly, although in fairness, I think that was kind of an easy question to guess at. Most people did still perceive that there are risks for the different diseases, and in analyzing it two ways, there was generally an understanding that you should use snus exclusively to get reduced risks. But I think, again, the issue is, we don't know to what extent this understanding is attributable to the claim, or these people who were users to begin with already had kind of favorable and accurate perceptions, and that might be, because of the design. So.
Lucy.
Very quickly, another point I wanted to bring up is that the question about understanding of complete switching being necessary to reduce risk, this question was only asked of people who answered correctly to the previous question. So it wasn't asked of people who already had some misunderstanding. So this is further reduces our ability to generalize or to say, like, okay, what is actual understanding of the need to switch completely? And in our studies, when we do it with general population of smokers, we see like much higher rates of misunderstanding that, and it's not necessarily like how many cigarettes can you smoke to get the benefit, but more like if you switch completely, if you use exclusively, and people have a hard time understanding that.
Risa?
Thank you. I want to make an observation about the warning label. It says using snus instead of cigarettes puts you at lower risk, and it doesn't say using snus exclusively instead of. And I noticed that that's the language directly from the FDA when comparing snus to cigarettes. But the language from the FDA when referring this general snus to other smokeless tobacco products, they specifically say, and when used exclusively instead of other smokeless tobacco products. So I feel like the word missing is exclusively, and for me personally, that would make things super clear.
Nancy?
Oh. Can I just? Yeah. I want to make sure I understand what the point is. The authorized claim, the claim that we authorized, it's not a warning label. It's a modified risk claim. This was what the company requested, and so the company provided the Mrtp application, our initial review of the application, evaluated whether that statement was scientifically substantiated, and then there was consumer perception testing, so we evaluated whether people understood that, and then, determined whether the product meaningfully reduced the risk of disease and benefited the population as a whole. And that's how we sort of that's how we ended up with modified risk authorization. And so that authorization is for that specific claim that was proposed to be used in marketing by the applicant. Other statements that FDA might have made in the review, the decision summary, just reflects our evaluation of the scientific evidence. It's not a statement that the company is authorized to use in marketing. They would have had to request that through the modified risk tobacco product review process. So hopefully that just clarifies the distinction between the different statements.
And because words matter, I'm going to reread exactly what the authorized claim is. Using general snus instead of cigarettes puts you at lower risk of mouth cancer, heart disease, lung cancer, stroke, emphysema, and chronic bronchitis. So that is the reduced risk claim that general snus was allowed to make.
May I follow up? Am I correct in that that's only true if they exclusively switch and don't use anything else? Because I also heard others here say, well, they switch for one session and use snus instead of cigarettes, but then they switch back to cigarettes. So is the health claim only valid if they exclusively switch, maybe using the 30-day use criteria?
So I'm going to ask Ben, was the intent of the modified risk statement to imply exclusive switching?
Like, say exclusive switking, maybe based on the...
switching, exclusive.
Using the 30-day use criteria, because that seems to be something that we gravitate towards.
Well, there are two different things. I mean, how you assess whether someone is, like how you assess what products people are using and whether they're exclusive users or not. I mean, that's like an assessment of behavior. This was a statement that was proposed, and part of that was an evaluation of consumer perception data. How do people interpret and understand that statement? And so that included in the original submission evidence related to ensuring that people understood that if they dual use, they'd be at greater risk than if they just use the product exclusively. So that, yeah, is baked into the statement, but that's all based on our evaluation of the consumer understanding of that claim. And so that actually was debated and deliberated on in a prior TPSAC meeting when we were meeting to talk about the authorization. I remember a lot of discussion around different language instead of or completely switch or other kinds of terminology, and people had a lot of different ideas about it. But what we try to do is just look at the scientific evidence that is really looking at, like, that was an experimental study where, individuals were shown the product with the claim and then asked, a series of questions about it regarding their understanding. But then in the post-market context, the purpose of this study partially was to just continue to ensure that people generally understood that the product has risks, that it's not risk-free. I mean, these are all tobacco products. They're all harmful products, that it's less harmful than cigarettes, and that using it exclusively would pose a lower risk than if you used and dual used.
So we can't go back in a time machine, but if I'm, so because of the concern of dual use, though, the intent of the risk claim is supposed to capture complete switching. Is that right? Language says instead of cigarettes.
Yes, there's different language that you could use to imply, using one product.
Maybe better language if it's renewed. If people understand instead of doesn't mean today I use general snus, tomorrow I use cigarettes. That's not complete switching. It technically is definitionally correct. You did use it instead on day one, but on the even days you used one product, and on the odd days you used the other.
Yeah, well, I think that's why it's helpful to understand the committee's perspective on the understanding data that we have, like post-market. I think Olivia talked about was helpful, sort of context for thinking about what we can take away from that.
Nancy.
So when I look at the wording of the modified risk statement, it seems to me that I get it. I get what it's saying, that it implies complete switching. I can also see where you could, sort of see it a different way. And I think the question would be that, what is the FDA going to want to require of modified risk statements data about that in order to accept modified risk statements. That's not really a question of, is this okay, you know, will we renew this one, but would, you know, the next time a product comes along, how much level of detail, because understanding the health communication science is really complicated as I understand it. And to make sure that something is really as crisp and as well understood as possible, is that what's being asked of the manufacturers to do that level? Because it didn't seem like that's probably what happened in 5 years ago.
Yeah, I will just say, actually, following this discussion of the Swedish Match applications, we're going to have a short session on consumer understanding and operationalizing it, and I think we can get into a lot of the specifics there. I will just say, you know, we have not articulated that there are certain language that's the right language to use because we know for sure that it's, you know, more well understood. What we require is that a company propose language and then test that language, and it's the scientific evidence we're evaluating through that testing to ensure that people comprehend it in a way that's going to ensure that they understand it accurately and are more likely to use the product in a way that can benefit them. So I'll reiterate that, and I do agree though with you that it's not really the task at hand to kind of revisit whether that claim was the right claim or there should be a different claim, and that was the claim that was authorized, and it just would be helpful to know if there is concern now for some reason that people don't understand that, or is it just, or does the evidence before us suggest otherwise?
Nancy.
So I was sort of getting to that, and I think that we can't. I guess the question is, would the recommendation be to go back to the company and the manufacturers and say, you need to make it better before we would renew this? I think that would be the question, and if we did, then we'd have to be clear on exactly what it would take. What I'm hearing here is that we are not, I think we've been able to say that it doesn't look like the youth are picking this up in a big way. At least they're not picking up smokeless in a big way, and probably not this specific brand, but we don't have the data that it's not this specific brand. But do we need that level of data in order to feel like the modified risk categorization is okay? And do we need, we can't, as Olivia pointed out, we can't say that it's the statement that is changing the behavior, but the behavior looks like there's something happening. Is it really that much? Is it really that valuable? Who knows? But it looks like it's not going in the wrong direction. And so if we want to get that level of detail, then we need to probably make it clearer to the manufacturers that that's what they need. It makes their job a lot more expensive, but presumably they're in business and maybe they can afford it. And that it just means that the process of getting this regulation will be more difficult and more expensive. But if that's what we think we need in order for us to feel that we're protecting the public, then that's what we're talking about. But if we don't need that level of detail, then in a very broad sense, at least certainly when I came in after reading the materials and after hearing the presentations, I thought it was, you know, reasonable. It wasn't perfect. Maybe some more analysis could help, but I thought it was, you know, not as bad as some others are interpreting it here.
So in the interest of time and getting some saturation with the kind of comments, and Nancy, it sounded like that would be your final comment. Is that your final comment here? No, you can't leave, but I won't call on you again. If you wish to add something again later on, you may. But with that, we're going to start to go around the room. I hope, Annette, you're okay. I'm going to call on you first. We started at that end of the table. Any final comments you wish to make regarding questions 1 and or 2, or broadly about the application that we are considering?
But you keep starting with me, and I'm not ready. Hold on. So I think related to the behaviors, the question 1, I think all potential patterns were not examined. So I think there's more nuance that needs to be examined related to question 1. And then related to question 2, is this what you're asking for, Chris? Okay. Related to question 2, I share Dr. Leventhal's comment around the emphasis on lower risk and how that may affect perceptions, but I also agree with Lisa around the general sense that snus is less harmful than cigarettes in general. I just also want to point out, and I know we're going to talk more about this, that the assessment of knowledge is not the same as the assessment of perceptions, and I saw in the write-up that that was very muddy. And so questions related to knowledge are separate from questions related to beliefs about harm of a product. I'll stop there.
Thank you. Andy?
Yeah, I'll just make a general comment here. I know there's been some questions about the renewal, but I would argue that really, if you think about Swedish snus, it's quite possibly the least harmful tobacco product that has ever been on the market, I think. And so we got to keep that in mind. It's a small market share too, and there's small sample sizes, I think, that come into play that make some of the details a little bit more difficult to get to. But if we think about this product and the history of Swedish snus and the harm level of it, very low, obviously, it's if this product can't maintain modified risk status, I don't know if any of them can. That's my comment.
Amy?
I just have a general comment with respect to the product, General Snus. It's, I think, been really well demonstrated. It's a significant reduced harm product. And one thing that really kind of struck me in the presentations that were provided is that when you're looking at a modified risk claim, in other types of products like classic snuff, is that communication is given to broader channels. And when you look at the reduced harm of General Snus, it's greater when you're looking at known human carcinogens like NNN, NNK. So I think there is an opportunity here for FDA to consider some even-handed guidance to the applicant in channels to communicate those reduced risk communications to consumers and really give smokers an opportunity for reduced harm nicotine products.
Maria?
So I believe that the consumer have a right for truthful and accurate information, and we should be able to reach out to the target audience and communicate. At the same time, I also believe that, currently the post-market surveillance studies had some limitations, but I think it doesn't disqualify the knowledge that the General Snus is significantly less risky than conventional cigarettes. And even from the studies, although we cannot really relate it to the impact of the claim, we see that there are some smokers who are completely switching to General Snus. And I believe that, we should be really thinking about how we can reach the target audience without creating unintended consequences so that the consumer have more information available for them to make informed choices. And then for the post-market surveillance, I think we should be thinking, how to tailor the post-market surveillance studies to really get to the question of what we need to get, and not making it so burdensome on the manufacturers that they will never try to apply for Mrtp, and therefore we will have no products, nor information to communicate to adult tobacco consumers.
Thank you. Taryn?
Thank you for the opportunity to be here. I have some homework and information to relay back to my IHS colleagues, but just my comments initially is just looking at more closely at data contributions at the IHS level and how we can provide more feedback, and looking closely at marketing efforts among American Indians, Alaska Natives. Thank you.
Dee.
I agree with Scout's recommendation that the public commenters should be required to disclose tobacco industry ties and potential conflicts of interest. I saw no new information today that would cause me not to recommend a renewal. The extremely low rates of nitrosamine levels, low levels of use among the youth in particular, from what we've been able to see. However, I would not recommend expanding the use of the claim, particularly the request to point of sale and social media and digital platforms. I would find to be problematic given all the concerns raised here by my colleagues here around the data that have been discussed and the co-marketing and the halo effects that have been discussed and other concerns. And if possible, and I'm also concerned about dual use and the switching, right? And for us to have the most benefit, we want people to quit completely. Certainly to completely quit combustible tobacco use. And I guess I'd like to really encourage FDA to work with the applicant to change the language of the claim to be clear and clarify that we're talking about exclusive use or completely switching so that consumers really understand how they're able to gain the best public health benefit.
Lisa.
Yeah, so I agree with my colleagues about clarifying the exclusive use aspect. Generally speaking, it's unclear to me what the threshold is for the FDA to determine that something is reduced risk and then whether the public has the same understanding of what that threshold is as the FDA. So I think in this case, I don't really have an issue with it, but I could imagine cases where the FDA's threshold might be different than the public's understanding of what reduced risk is. And I think that's just something to think about for the future. Regarding the expanded use, I'm actually going to disagree with Dee here. If the FDA feels that the MRTP claim is in the benefit of public health, then it should be easier to get that information than it looks like it is from what they're doing here. People have to put quite a bit of personal information into the website in order to see the claim, which personally I would never do that. So anyway, so yeah.
Lucy.
Oh, I want to say thank you to the FDA for all the work they've done, putting all the materials together and comment through all that. And also to the company, because they're the first one doing this in a few years back, and now the first renewal. So in that, it's, we're all in this together, and now I'm going to give you some things to consider and maybe make clearer and improve the process. In terms of health actual claims, going back to, we do know that this is a very low risk if this is used by non-smokers who never smoke. Since we've had a lot of studies now kind of looking at the switching patterns and biomarkers and all of that, I think moving forward, we do need to take that into consideration. Do we have enough evidence and scientific base to say, yes, switching completely will actually benefit you? Because right now we know if you never smoked and use it, this will be better than smoking. In terms of the studies post-marketing surveillance, I think we need to make very clear what are our research questions and then design the studies around that. If we're looking at impact, it's a different study. If we're looking at patterns of transition and cohort, it answers different questions. FDA needs to be very clear in what study is going to be done, what research questions they're going to answer, and then communicate that not to just companies, but the public and to us. And we can provide that feedback early on rather than 4 years later when the study has been done and we're like, well, this is doesn't give us the information we were looking for. And in terms of what Ben was asking in terms of what studies can we do, how can we better do it, I think that, again, whatever is the research question, this is what the study should be done. If we need to know how the claim affects perceptions and behavior, this is like a study of marketing campaigns. This is when we put, FDA does marketing, prevention campaigns and all of that. You look and see how is exposure related to outcomes. Very simple. So we need to, could be a study design, and there's a lot of literature on how to evaluate real world communication efforts instead of just doing the lab studies, the experiments which are done at the early stage. And we didn't talk too much about the expanding the marketing, but I agree that smokers should have that information. And Swedish Match is part of PMI. PMI has a huge database of smokers. They could devise a study where they, I think direct mail to smokers would be very appropriate. They do send coupons. They have all that information. Why can't they track that information, create a study to show, okay, does this claim track in, do people buy it, do people not buy it? They can have very sophisticated designs. They probably already run in those studies, just not sharing them with us. But anyways, there's a lot of things available out there to do this properly and to see real-world impact of this modified risk claim. But for right now, the evidence presented, it's just not sufficient to say one way or another. It's like we don't have really any new evidence compared to where we were 5 years ago.
Adam.
So based on the evidence reviewed today, the claim as written appears to be accurate in terms of the health effects, so no new data coming out to suggest one way or the other. Now, in terms of allowing the MRTP claims and its impact on public health and kind of both sides of the coin, I do agree with Dee that to mitigate the adverse impact on youth uptake and young adult uptake, which we didn't have much data presented today on, limiting the channels of marketing to venues where people who don't currently use combustible tobacco products are unlikely to see. So like, for instance, stores that you have to be 21 and up to enter, the website gating, those would be ways to protect against that concern.
Sven?
Right. Yes, I concur with several of the other panel members in that the language of the reduced risk claim needs to be more precise, stating that it's not just, you should not smoke at any time, right? You cannot just use these interchangeably, that you really have to, quit using cigarettes, but also that you should consider not using other nicotine products because the risk associated with other products such as e-cigarettes and others is not really clear. In terms of, having hidden this statement in several layers of web forms with a lot of information, I think that's in fact counterproductive. So being able to present this claim in other contexts would probably help. I still remain concerned a lot about the dual use, and I hope the rephrasing of this claim might help with that, if that's possible. And if this MRTP renewal is approved, FDA needs to expand its monitoring of health effects towards other biomarkers, other indications, such as mucosal lesions linked to diabetes and other factors. We already have 10 years of user data, and we'll have, if this is for 5 years, or if it's extended to 10 years, that should be possible. Thank you.
Risa?
So I do agree that we have a reduced exposure product here as assessed on the benchtop. I think on a population level, the data are less clear, and that's mainly around the messaging with using the words instead of and versus exclusive use instead of. I'm also concerned about youth initiation, as my colleague Scout here mentioned, that on college campuses, if we expand the advertising, we might have an uptick in more college students initiating this type of use. That's all. Thank you.
Scout.
I remain very concerned that the strength of evidence provided to us would not pass NIH study section to get funded. There's just so many things that have been brought up, concerns about the exact wording, on how this was presented to people, no research on dual users, concerns about the attrition, which I understand while the original study was approved, the attrition rate was obviously not approved. And considering this is a set of industries that are absolute magicians in getting people to continue doing things, it's kind of amazing that they couldn't get them to take a third survey. I mean, give them a free cappuccino maker if they go through all three. Post-weight their actual remuneration so that they are incentivized to get through all of, 4 waves, I guess it was. Also concerned about the fact that there was nothing like imputation, other loss to follow-up strategies put in place in order to minimize that. They didn't match the referent population that they had from past with any kind of indication, so the fact that we have high SES population at wave 4 makes me really dubious about the value of any of the information that's even coming out of that. And you add on the fact that we're talking long gestation periods for some of these outcomes that are part of the evidence base, that this is lower risk, makes that suspect as well. And then add on the fact that the warning currently is only accurate for about 1/4 of the users, and for 3/4 of the users, it's an aspirational warning, and yet 100% of the users are going to be reading that and presumably thinking that that is a science base that they can react to. Then, if we look at the actual wording of it, I am certainly concerned that it's not well understood the way it's currently put out, that we didn't have information on modified risk claims for youth, that we have now heard for the first time here that there was a bunch of redacted information at youth in these applications, and we have no access to that whatsoever. That absolutely makes me concerned as well. So I think not even counting what the placement effects of these claims might be, that may not be within Swedish Match's purview to look at, but maybe it's really in FDA's purview to look at, that we need to understand more about the halo effects here, particularly when it's put next to things that are having runaway success in different populations. So ultimately, I judge this to be a claim with a gargantuan asterisk next to it that is not publicly conveyed, and we're expecting that the population will somehow guess all of the caveats at the end of the claim.
Nancy, do you have anything to add?
I think I would add that I think that it's reasonable to consider expanding the ways in which it could be marketed, although I have some concerns about the point of sale, because it's going to be sitting next to other, it's not going to be sitting next to cigarettes, it's going to be sitting next to something else.
I agree that we weren't presented with any data to negate the claim from what it was before, and with the concerns for the wording. And if the wording on the claim is changed, I think a great deal of care needs to be taken. I think for this population of many people with lower education and lower socioeconomic status, they may not understand what the use of exclusive means in this context. So I think it's important to change the wording, but with great care. I remain skeptical of studies that are done by the industry or done by anybody who has a biased interest in the outcome. So I would really encourage FDA to do their own studies or to get funding for other people to do the studies. And I agree that we have a big concern for dual use and of initiation of non-smokers of our youth, and so I would be careful about expanding where the claim can be stated. It might be reasonable to do it in other places, but again, we have to be careful where youth are going to see that. Thank you.
Olivia.
In terms of the data we looked at, I think that there's some evidence that there may be some benefit, minimal benefit so far, but I think we also haven't seen any compelling evidence that there's been harm or unintended consequences. In terms of the perception data, I think, as we said, we're missing some critical information about potential claim exposure or connection to that, although at least some of the consumers that data was obtained from, if they were consumers for 2 years, potentially would have seen some of it, but as has been mentioned, it's, pretty varied. And with that, talking about sort of the claim expansion, I think it's reasonable to consider other channels. If nobody ever sees the claim, then, we really don't have a purpose to have it. But as others have said, I think we need to be careful about which channels those are to limit youth exposure.
Mignon?
Thank you. Regarding the data presented, I'm not going to belabor the previous comments, but continue to have concerns expressed about the rigor of the study and potential health risks associated with the use of other tobacco products other than cigarettes. I am also concerned about the potential for confusion on the part of consumers, as my other colleagues have expressed, about the MRTP claim. I agree that the FDA and the manufacturer both have to be very, very clear about exclusive use at this table using that term, but also knowing that we'd have to modify that language and ensure that it's accessible to the individuals that are actually using these products. I think about the gentleman who spoke earlier about the folks who use it are from, I thought he said Appalachia, but I can't remember, and truck country, potentially individuals with lower levels of education, lower levels of health literacy and things of that nature. So we have to be very clear that we're very clear about the language that we're using for the populations that are using the products. And for those reasons, I agree with my colleagues that I wouldn't recommend expansion of disseminating the MRTP claim to the point of sale on social media at this point in time. This is not something, that we want to roll out into all sorts of domains without having adequate data to substantiate the safety of doing that, of that act in and of itself, and then have to pull back with putting out fires, as we often do within the tobacco control domain. That would be it.
Thank you. There are over 28 million people in the U.S. that smoke combustible cigarettes. And on the continuum of risk, this product, as far as a tobacco product is concerned, not tobacco and nicotine, but as far as the tobacco product is concerned, is on the opposite end of that continuum of risk. Has the MRTP for general snus helped us realize what its potential could be? No, it's really hard to evaluate. The low sales, perhaps due in part to the very conservative marketing approach used by the company, which makes that a little challenging. Did the general snus MRTP promote youth uptake? The data seem to suggest no. So that's, I think, a good thing. Did the general snus product produce switching like we would hope? It's unclear. It's hard to tell in the data. And so I ask FDA if they can do some more robust analyses, perhaps stratified analyses by the use of other tobacco product types, I think would be important. I remain concerned that maybe some of the changes we're seeing are just secular changes, or what we know about people that use a variety of tobacco products is they use a variety of tobacco products. And so it could be the e-cigarette that helped that combusted cigarette smoker transition off of the cigarette and not the general snus product. We don't know. Hopefully FDA can take a closer look at that. The post-marketing studies in general, I think, need to be designed a little bit better and a little bit stronger. And then the last comment I'd like to make is ask FDA to consider also reevaluating their proposed product standard for smokeless tobacco, which they made a number of years ago. This particular product would meet that product standard. The companies are capable of producing smokeless tobacco products with very low levels of NNN, and perhaps that is something worth considering reevaluating at this point. And with that, I'm going to let Ben have the last word.
Can I say just one more thing? Just very briefly, sorry.
Only if I acknowledge you, Adam. No, Adam, yes, of course.
All right, thanks. I was going to say, one thing, one recommendation is if there is a renewal of the MRTP, all FDA-related communications could help provide context to provide information to avoid halo effects, so kind of reinforcing that an MRTP renewal does not necessarily mean less harmful than other products, and it's specific to this product, this brand.
Great, thanks. You know, I'll just say really, at FDA, we really appreciate the committee taking the time and, you know, really putting in the effort to prepare and to, you know, to really consider the evidence and all the various questions that were raised today. We, you know, we're going to have the transcript to be able to go back to really dig deeper into everyone's comments and feedback. And so we just really appreciate the time and effort that's gone into the discussions today. So just thanks.
And with that, we're going to take a 10-minute break, and when we return, we're going to hear another presentation from FDA.
Okay, everyone, we're going to go ahead and get started. If you could take your seat. Thank you.
Okay, we're into the home stretch. I would like to introduce our next speaker, Alex Prasosky from FDA, who's going to talk to us about consumer understanding across MRTPAs.
Okay. Hi, everybody. I'm just going to see if I know how to use this. Okay, just testing that out. My name is Alex Persofsky. I am a supervisory social scientist in the Division of Population Health Science in CTP's Office of Science. And I'll be giving a general overview of CTP's evaluation of consumer understanding in modified risk tobacco product applications. And the goal is going to be to tee up the committee's discussion of 4 questions that we're seeking your input and recommendations on. So this presentation is not a formal dissemination of information and does not represent agency position or policy. First, I'll start by going over some relevant regulatory background to set the context for the discussion of consumer understanding and explain why consumer understanding matters. Second, I'll describe modified risk labels, labeling, and advertising, including explaining what these are and what types of content we've seen on them in MRTPAs up to this point. Third, I'll present a potential framework for assessing consumer understanding of MRTPs. Fourth, I'll describe some psychological constructs that are relevant to assessing consumers' understanding of modified risk information. Fifth, I'll go over some considerations about measurement of these constructs. And then last, I'll introduce the questions that we have for the committee. So first, the regulatory context and background. When an applicant submits an MRTPA, FDA's scientific review includes evaluations of many types of information. We need to characterize the product itself, which, depending on when it originally came onto the U.S. market, may or may not have previously gone through an application pathway such as PMTA. We have to identify the modified risk information that the applicant proposes to market the product with, substantiate that the modified risk information is accurate, and evaluate the overall health risks of the proposed MRTP relative to the comparison product, which might include health effects that are not described in the modified risk information itself, but would still affect people who use the product. We need to evaluate consumer understanding of the information, which is the focus of my presentation today. And we need to evaluate the MRTP's impact on the population as a whole, including people who currently use tobacco products and those who do not. And we need to conduct an environmental assessment. In our reviews, we consider all available scientific information that we can, including information provided in the application, as well as other information such as that submitted in public comments or published in the scientific literature if we're aware of it. When Congress passed the Family Smoking Prevention and Tobacco Control Act, or Tobacco Control Act for short, and the President signed it into law in 2009, they made several findings, including that tobacco product advertising and marketing have historically been directed to attract young people to use tobacco products, and advertising had portrayed the use of tobacco as healthful, including to minors. Congress also found that among people who currently use tobacco products, marketing products as modified risk when they do not, in fact, reduce risk could lead people to continue using the products rather than quitting or reducing their use of tobacco. A primary example of this was that many smokers mistakenly believed that light and low-tar cigarettes caused fewer health problems than other cigarettes, which reduced their motivation to quit smoking. Congress also found that advertisements in which one product is claimed to be less harmful than another product had been misinterpreted by consumers, even in the presence of disclosures and advisories intended to provide clarification. Given such risks, Congress concluded that there was a compelling government interest in ensuring statements about modified risk products are complete, accurate, and relate to the overall disease risk of the product, and that FDA was the appropriate regulatory agency to evaluate modified risk tobacco products, including evaluating the consumer impact of labels, labeling, and advertising that contain information about modified risk. They tasked FDA with reviewing tobacco products sold or distributed for use to reduce risks or exposures. And they stated that prior to marketing such products, it is essential that manufacturers be required to demonstrate that such products will meet a series of rigorous criteria and will benefit the health of the population as a whole, taking into account both the users of tobacco products and persons who do not currently use tobacco products. When it comes to consumer understanding of MRTPs, the Federal Food, Drug, and Cosmetic Act, as amended by the Tobacco Control Act, lays out a general standard for what needs to be demonstrated. The standard, which is in Section 911H1 of the FD&C Act, states that the HHS Secretary shall require that any advertising or labeling concerning MRTPs enable the public to comprehend the information concerning modified risk and to understand the relative significance of the information in the context of total health and in relation to all the diseases and conditions associated with tobacco use. That brings us to the role of consumer understanding in modified risk tobacco product applications. Consumer understanding is a standalone statutory requirement that must be met to receive a modified risk granted order, or MRGO. We also need to evaluate consumer understanding because it is one factor among many that can influence people's use of tobacco products, including initiation, cessation, using products more versus less frequently, and switching between different types of tobacco products. For example, people may have misperceptions about the health harms and addictiveness of cigarettes and other tobacco products. Prospective studies suggest that lower perceptions of risk among adolescents are associated with greater likelihood of initiating cigarettes. Perceived risk and vulnerability also predict smoking quit attempts and cessation among adults in longitudinal studies. That means consumer understanding plays a role in the health effects of authorizing the marketing of an MRTP. Let's now get into modified risk labels, labeling, and advertising, including what these are and what types of content we've seen on them in MRTPAs up to this point. Briefly, I want to explain this term LLA, which might sound a bit odd or redundant. We use this term LLA because it is written into Section 911 of the FD&C Act. Basically, labels include displays on containers or packages. Here is an example of the front and back labels from a Camel Snus MRTPA that was discussed in a TPSAC meeting back in 2018. I'm using Camel Snus as an example here because they had all three types of materials. Labeling is more general and includes labels as well as other materials that can come along with a product. Again, from the Camel Snus MRTPAs, here's a part of a consumer engagement handout that was proposed to be used by company representatives when engaging consumers in adult-only facilities and at retail. And then advertising isn't explicitly defined in the Act. Advertising might sometimes be discussed in terms of its intent as being directed to attract people to use tobacco products, or its effect of expanding the size of the tobacco market by increasing consumption of tobacco products. And there are many types of advertising channels and media as listed here. Also shown is an example of the outside and inside of a direct mail advertisement. So modified risk LLA contain modified risk information. In other words, information that represents that the product presents a lower disease risk, is less harmful than another tobacco product, or contains or presents a reduced level or exposure to a substance or is free of a substance. Typically, in MRTPAs we've received up to this point, the LLA has included information about the reduced risk or exposure, including statements that the product is lower risk or presents less exposure to a substance than another product, as well as information about how to use the product to get the risk or exposure reduction, such as a description of use patterns or use instructions. In some cases, the LLA has also included general product information to explain what the products are. Information sometimes referred to as balancing information to put the modified risk information in context. For example, statements that the best choice for one's health is to quit all tobacco products. And information sometimes referred to as disclaimers that says what the modified risk information does not mean. As suggested previously on the LLA slide, modified risk information may be included on labeling or labels that come with a product once a consumer has purchased it, and it may also appear in advertising such as direct mail, email, point of sale, print, and digital media that consumers can view even if they haven't purchased or otherwise come into contact with the product yet. Different types of LLA can be designed for targeting and tailoring to various potential audiences. For example, certain advertising channels can be used to directly target potential consumers who currently use the comparator product or who are over the federal minimum age of sale of tobacco products. And advertisements can be tailored to appeal to particular groups through imagery or other characteristics. This slide shows snippets from example advertisements from some previous MRTPAs. The one on the left is from an email ad for General Snus, and the one in the middle is a print ad for IQOS, and the one on the right is a print ad for VLN cigarettes. Here you can see the modified risk information, other information about the products, branding, and images of products and packages. Let's now move into a potential framework for assessing consumer understanding of MRTPs. This slide shows one potential way of breaking down and thinking about adequate consumer understanding of MRTPs. As a reminder, Section 911H1 says that modified risk LLA must enable the public to comprehend the modified risk information and understand its relative significance in the context of total health and in relation to all tobacco-related diseases, but it does not give the specific ways in which FDA should assess this. Based on the ways we have approached this provision in the past, this slide reflects a potential framework that breaks consumer understanding into three components or buckets. We're seeking TPSAC's early input on this potential framework as part of the discussion questions that will follow this presentation. This potential framework includes, on the left, understanding the specific risk reduction or exposure reduction that the LLA described. In the middle, understanding that the proposed MRTP does confer health risks or harm and is more harmful than non-use, and understanding the risk relative to cessation with or without the use of FDA-approved cessation therapies. And then on the right, understanding how to use the proposed MRTP to reduce one's risk or exposure. So let's now look at each component in more detail. This first component of the potential framework is about whether the LLA would enable consumers to understand that the MRTP poses less risk of the outcomes it talks about, particular diseases, health effects, harms, or exposures. For example, for LLA with information about reduced risk of diseases A, B, and C, would consumers understand that the product presents lower risk of these diseases than the comparator product? This second component of the potential framework is about whether the LLA would enable consumers to understand the extent of the health risks and harms that the MRTP does still confer. This includes many diseases and harms, including addiction. This gets to the absolute levels of health risks, which for a young person who doesn't use any tobacco products implies a comparison with non-use, and for someone who currently uses tobacco products would imply a comparison with cessation of all tobacco use. Also, it would be important to ensure that current tobacco users understand the health risks and harms of using an MRTP compared to quitting all tobacco through the use of cessation therapies that have been shown to be safe and effective. The third component of the potential framework is about whether the LLA would enable consumers to understand how they have to use the MRTP to reduce their risk of disease, harm, or exposure. In what we've seen to date in MRTPAs, this has mainly involved switching completely from the comparator product to the MRTP and no longer using the comparator product, but one application was for very low nicotine combusted cigarette products and also had the stipulation that people needed to substantially cut down on their overall cigarette smoking. We've seen various phrasing across different MRTPAs, and researchers have been conducting generalized work to evaluate whether people understand various phrases and different potential ways of getting across to consumers the idea of complete switching. Not all such phrases might be readily understood by consumers, and people might misinterpret them in particular ways, and so it's important for FDA to evaluate the information on a case-by-case basis in applications. Let's now talk about the constructs and information we have considered in the past when evaluating consumer understanding. In terms of how we have operationalized consumer understanding, our view has been that understanding is multi-layered and there are multiple overlapping ways of conceptualizing and measuring it. Given the focus on risk in MRTPAs, in the past we have been interested in comprehension of risk-related information at a surface level and also understanding of that information at a deeper level, including consumers' understanding of its significance and meaning for their overall health. As shown in the figure here, labeling and advertising have characteristics that influence their understandability, such as readability. And then, once consumers view the labeling and advertising, research can use various methods to probe consumers' understanding in different ways. This can involve probing their basic comprehension, their knowledge, and their perceptions of risk. So as I just suggested, evidence on consumer understanding can generally come from two main sources, and I wanted to give a quick overview of these before going into each one in more detail on subsequent slides. First is the LLA itself, which we examined to determine whether it appears understandable. And the second is research in which consumers view proposed modified risk LLA and answer questions about the LLA, the product, and their risk perceptions to evaluate whether representative members of the public actually understand it. We call these types of studies tobacco product perception and intention studies, or TPI studies for short. TPI studies can be conducted by the applicant or by other researchers. They can be submitted in the Mrtp itself, or they can be referenced or provided to FDA in public comments. They can also be published in the scientific literature, and we can become aware of them that way. However, general findings from the broader scientific literature may not be informative for a particular application, given that each application is product-specific and has specific modified risk information that may or may not be similar to the wording that was tested in a study. As far as study designs, TPI studies can be qualitative, such as in-depth interviews or focus groups. They can be quantitative surveys, or they can use mixed methods. Each study design has strengths, weaknesses, and utility. So we generally suggest applicants consider using both qualitative and quantitative methods when conducting TPI research. For example, qualitative study designs can be useful to develop different presentations of modified risk information in ways that can be later tested in quantitative studies. And quantitative study designs can provide numeric estimates of the proportions of the study population who have an acceptable understanding. As noted here, in 2022, FDA published a guidance for industry on principles for designing and conducting TPI studies, which provides the agency's current thinking on the design of such studies. Okay, so getting into each type of evidence, we start with the labels, labeling, and advertising itself. In past reviews, we have considered the extent to which the information on the LLA on its face would appear to promote the public's understanding of the product's risks. So first, does the information appear to be accurate and not misleading? For example, is the proposed information exceedingly broad in its reference to reducing tobacco-related diseases or harm? Does the information purport that the product's risks are lower than can be substantiated? Depending on the facts, this can be misleading on its face. Second, does the information appear readable, clear, and comprehensible to people, even if they do not have a high level of formal education? We have looked at factors such as reading level scores, but we're more concerned with overall apparent clarity and salience of the main ideas. Third, does the information explicitly describe how one needs to use the product in order to reduce their risk, harm, or exposure? In terms of evidence from TPI studies, we consider a variety of outcomes collected from participants either while they're viewing the modified risk LLA or after they finish viewing the LLA. In other words, some measures of consumer understanding give participants the opportunity to view the modified risk LLA while they are completing the survey items or questionnaires, whereas for other outcomes, participants view the modified risk LLA for a period of time and then complete questionnaires without referring back to it. We can generally lump the consumer understanding outcomes into three categories shown in the circles here. I'll go into more detail about these on subsequent slides, but these include recognition and recall, knowledge, and risk perceptions. We view these as falling on a continuum in terms of the depth of understanding that they each show, with some outcomes reflecting a shallower or more verbatim understanding and other outcomes reflecting a deeper understanding. We want to note that each construct gives us a different type of information about consumer understanding, and together, different constructs may complement each other. Recognition and recall, for instance, reflect surface-level understanding and are a low bar and first step for evaluating whether people really get it. A few examples of items from published studies are on this slide. Since recall items usually ask participants to provide an open-ended response, they also could be influenced by other factors such as education, age, or health literacy. Another note regarding recognition and recall measures is that participants cannot view the modified risk information while completing the questions, and so the items are, in part, capturing the memory of the claim and not just comprehension of it. Also, whether questions include cues can affect results, such as the likelihood of participants responding "don't know." The next construct, knowledge, goes a bit deeper and asks people to spontaneously interpret the modified risk information and push on what it actually means in a way that relates to real-world use and health effects or exposures. These questions can be quantitative or more qualitative in nature. The final construct, risk perceptions, refers to people's judgments about the likelihood or severity of health effects from using tobacco products. Given that the key information consumers need to understand concerns risk perceptions are an important construct to assess when evaluating consumer understanding. There is significant published literature on tobacco risk perceptions, and they generally break risk perceptions out into two types. Absolute risk perceptions are judgments about the health risks of using the product in an absolute sense, such as whether a consumer expects a certain product use pattern to cause health harms. When evaluating consumer understanding in MRTPA review, it can sometimes be challenging to judge the accuracy of absolute risk perceptions, as there can be a lack of consistency in how respondents interpret and use response scales, no matter how they are labeled, and that's the case for both verbal and numeric labels. Relative risk perceptions are judgments about the health risks of using the product compared to the health risks of using another product, such as the comparator product, other tobacco products in the same category, or FDA-approved cessation therapies. For both absolute and relative risk perception measures, we recommend being specific in terms of the health harms and the use patterns. For example, assessing the perceived health effects of partially versus completely switching to the MRTP. You can see how these added levels of specificity affect question wording in the examples on the right side of the slide. The last topic we'll talk about today, before getting into the questions, is measurement considerations. Some of the study design and questionnaire features that we have considered when evaluating consumer understanding evidence. As mentioned before, FDA put out a guidance that discusses principles for conducting TPI studies, and this presentation draws on what is in that guidance. Our first recommendation in the final TPI study guidance is to use an experimental design in which participants are randomized to a control group that does not view the modified risk LLA or an experimental group that does view it. Then, participants answer questions about the LLA and product's risks. This type of experiment can help demonstrate whether and how the modified risk information influences consumer understanding. Moving on to some considerations for the scales used to assess consumer understanding, which are on the left-hand side of this slide. FDA recommends including more than one type of measure or scale, and ensuring that items aren't too easy and that they have objectively correct answers so that they can be scored for accuracy. Otherwise, it's difficult to interpret the results and whether they reflect sufficient understanding. On the right side of the slide, we have some things to consider when assessing risk perceptions. We recommend that risk perception items be worded as specifically as possible. That helps ensure that we know what underlying belief the item is capturing and that all participants are thinking about the item similarly. This also helps us evaluate whether people's perceptions are accurate. For example, we recommend specifying the use conditions in risk perception items, things like duration of use and frequency of use, such as everyday, dual use, exclusive use, etc. When measuring any psychological construct, including recall, recognition, knowledge, and risk perceptions, it is critical to ensure that the measures are valid, given that the constructs are not directly observable. Validity means that a measure is a meaningful reflection of consumer understanding. That is, people who understand the risks and the modified risk information better will score more highly on the measures than will people who understand the modified risk information less well. We describe this further in the TPI study guidance that I mentioned previously. When evaluating the validity of measures of consumer understanding, we consider factors such as face validity, meaning the extent to which the measure appears on its face to tap into the construct and lack bias in terms of how it is written. We consider whether the items were cognitively tested to determine whether people similar to the study population correctly interpret what the items are asking and how to express their responses. We also consider whether the items were previously used in published literature that demonstrated their validity by finding expected statistical associations with validated measures of other constructs. And we consider whether the applicant conducted their own such validation research on the items. So lastly, before jumping into the questions that we have for the committee, here are some additional miscellaneous considerations. First, FDA's evaluation of consumer understanding in MRTPAs has been focused on the adequacy of people's understanding after viewing the modified risk LLA. We have not applied specific predetermined thresholds in terms of the percentage accuracy that we need to see on given questions. We have taken a holistic view that considers everything we know about the product, the LLA, the research, and the potential consequences of any potential misunderstandings that we see, if any. In addition to assessing the sufficiency or adequacy of people's understanding, we have also considered whether viewing the modified risk LLA improved people's understanding, such as by correcting some of the entrenched pre-existing beliefs that people may bring with them. Related to this, we acknowledge that people have pre-existing beliefs and perceptions about tobacco products and that they bring these with them when they view modified risk LLA. For example, many U.S. adults perceive that all smokeless tobacco products and snus are equally as harmful or more harmful than cigarettes. And we recognize that such beliefs can sometimes be resistant to change through exposure to new information in modified risk LLA. Relatedly, we recognize that people may respond differently to LLA when they view the LLA a single time in a brief single-session experiment or survey compared to consumers who view LLA repeatedly in the real world as they come into contact with the full marketing campaign. Lastly, we are cognizant that different types of misunderstandings can have different implications across different groups, and we have tried to take that into account. For example, if someone is not an intended user of an MRTP, for instance, if they are under the federal minimum age of sale of tobacco products, we would be more concerned if they underestimated rather than overestimated the harmfulness of tobacco products. So I want to quickly give an overview of the 4 questions before jumping into the discussion. The first question that we have for the committee is about this potential framework that I mentioned a moment ago. So we presented a potential framework for conceptualizing what aspects of consumer understanding should be demonstrated in MRTPAs, and we want to know what the committee thinks of this potential framework and whether you would suggest modifications. The second question is about the fact that most studies of consumer understanding involve presenting the LLA to participants as part of a controlled laboratory experiment, whereas in the real world, consumers could be exposed to LLA repeatedly and in various advertising formats. And we would like to know whether the committee expects consumer understanding to differ between real world and experimental settings, and if so, how we should be accounting for this in study designs and evaluations of experimental studies. And then more broadly, what does understanding in the real world look like, and how could CTP and applicants monitor this understanding as part of their PMSS? The third question is that there may be unique consumer understanding considerations for the intended and unintended users of an MRTP. And so should consumer understanding be assessed differently for these various groups? What are possible red flags that indicate consumers are misled or not understanding, and how could those red flags be measured? And then the final question, consumers bring with them pre-existing beliefs that affect how they interpret claim information and how they answer survey questions. So how, if at all, should FDA take these pre-existing beliefs into account when assessing and evaluating consumer understanding of claims? So I'll go back to the first one and then turn it back over to Dr. Del Navo.
Thanks, Alex. Just one kind of clarifying question is this is going to hopefully inform future MRTP applications. Is that right?
Yeah, I think that's right. I think what we're looking for is to really kind of building off of what we've talked about earlier, which was in the context of a single application, sort of more broadly, the approach that FDA is taking to evaluate consumer understanding. What is the perspective of the committee on that? Are there different things we should be considering? And that then can be used to inform not just us, but also the regulated industry and the kind of the types of evidence that we're looking for and how we might go about that evaluation. So yeah, it's really like more programmatic in terms of the approach that we're taking around this topic for MRTPs.
And I guess a related question is there are renewals in the pipeline, right? Like this is the first, but there are other products as well. Maybe the next one is coming up too soon for the manufacturer to potentially incorporate some of those things, but could there be, maybe it's just a comment, that there's an opportunity to pivot for the remaining products to incorporate some of these kind of best practices that folks are going to be discussing today? Scout, I know you need to leave soon, so
thanks. Yes, I appreciate it. I'm sorry, I do have another federal thing I have to leave for immediately. But to quickly kind of say responses to the questions, first of all, discussion question number one, yeah, I think another piece should be is adding and understanding the broader impact of this MRTPA, aside from just in that item, but in the real world scenario where we're bombarded with a lot of information. So what are the contextual, what are the placement impacts, different things like that I think should definitely be considered. And then that really rolls into discussion question number two. Yeah, I think we should be using real world scenarios instead of laboratory scenarios to understand people's conceptualization and understanding this. Things would be like VR experiments or VR scenarios that people can be immersed in, like what if you're in a convenience store and you're seeing these different kind of risk factors, is something that could be very simple. And then how can you monitor it in the future? Presumably they're going to have layers of these that continue to stack on top of each other. So I would actually consider, as you do the later testing, add the previous ones in that actual scenario, and then occasionally go to an offshoot study where you go back to the previous one and figure out whether it's still having the impact that is intended, and then also explore as the future one emerges whether in the layering of all these different warnings, people are understanding the graduated risk successfully. Next one, number three. Yes, definitely for the various populations, we have to understand that some examples would be that youth obviously have different types of reactions to risk scenarios, and we understand that, the tobacco industry already put out, youth warning labels that looked like they were warning youth away that were actually market tested to realize that they enticed youth. We also would anticipate in populations where there's antipathy or problems with the government, like the queer population or the Latine population, that we might have a different kind of reaction to government warnings or government perceived warnings on labels. So definitely needs to be population assessed. And then for number four, I think you obviously need to assess pre-existing beliefs before you do any kind of research. And then if you make the research a little bit more like clinical trials with an intervention and a non-intervention comparison, I think that would ultimately make it stronger. And I understand that there's concern that all these things offer a greater regulatory burden for the tobacco industry, but we are dealing with the public health burden of light cigarettes to this day. So unfortunately, I have little sympathy for the regulatory burden the tobacco industry caused us to need this level of oversight with all possible future risk information. With that, sorry, gotta go.
All right, so let's spend some time talking about discussion question number one. What do folks think about the potential framework with these three components? Is there anything missing, or would you suggest any modifications? Olivia.
I think the framework is good. I think it makes sense. I think it's pretty consistent with what has been used so far. I think if we want to consider potential additional things to think about, it might be relevant to assess understanding of who the intended audience of the claim is. Do adult smokers perceive that the claim is for them? Do youth who are exposed to the claim perceive that it is not for them? Do they perceive that it is for adults who use cigarettes? So I think that might be something relevant to assess. And you might see differences based on claim language. If the claim has switching completely language, that might be more of a clue about who the intended audience is than just use instead of. Thank you.
Lucy, we might have a ping pong between the two of you, was my prediction.
Well, I was really excited that this was included, and I commend the team on developing the framework and asking the good questions. I appreciate that it kind of went straight from understanding to operationalization, but then there was a little bit of conceptualization buried in there. And I think this conceptualization should be upfront. So what do we mean by understanding? And this is kind of, you guys got to that part. Is it just comprehending, meaning I understand what this claim says, but I don't agree with it? Or do we want people to agree and believe, which is, we're talking about persuasion. And this goes to different levels, and not just, and if we go deeper, there's more than just superficial belief, where like, I know smoking causes cancer, versus what Paul Slovic, his work done, where the deep knowledge, which is, do you know if you get lung cancer diagnosis, you have less than 3 years to live? And do you know how it would feel to tell your kids you have cancer? So like that kind of stuff is like very different and different level of understanding. And I think just going back and just inserting conceptualization earlier might be really helpful just in that. And it might be fine that we are actually limiting it to just superficial, because you're not going to get, with this claims, exposure, maybe in the website, kind of self-exposed. We probably won't get to that deep level of understanding at all. But we do need to know what effect do those claims have. And for that we have, and I think this framework fits nicely to see, okay, how do we measure all those things? Because we might not need a criteria on which we need to match, but we do need to have good measures to see what those claims do.
I guess the one thought I had was, would you ask the questions in a way that made it clear that the risk or the behavior being described affects me as opposed to affects people?
Well, Alex might want to chime in.
Sorry, yeah, I believe that was on one of the slides, but I didn't really focus on it. But yes, it is, yeah, and for risk perception measures, it's generally recommended that you ask about a person's own risk, because they might recognize a risk for other people, but not themselves. No, yeah, I did not focus on it, yeah.
There's a lot of kind of best practices for survey methodology on assessing harm perceptions of products. But my question is, this first bullet says risk or exposure. Could it be also risk and exposure, possibly, depending on the modified risk tobacco product and the claim that it's making? And then I know on an earlier slide, Alex, on the second bullet point, you mentioned cessation. And on the first slide, you sort of threw in nicotine replacement therapy. And I'm wondering what the thoughts are of FDA around assessing perceptions of modified risk tobacco products compared to medicinal over-the-counter or pharmaceutical products for cessation.
Piggybacking on that for a minute, Annette, is there's also just general misperceptions about nicotine and health risks, and that would be, we see that also in the NRT space as well, is a resistance to using NRT because of misperceptions about the dangers of nicotine. So I think that's a good point.
Yeah, so maybe how does NRT fit into this framework? Or does it, because you're the Center for Tobacco Products, you're not CEDAR? But it's very relevant, I think, when talking about these products.
Yeah, that's an important consideration for sure, because we want to make sure people aren't using MRTPs instead of using the products that have been shown to be safe and effective.
Lisa?
Yeah, I'm wondering, maybe you already done this, but have you brought in a focus group of users just to kind of understand the language that they're using and kind of where they're coming from?
Are you asking about research specifically done by FDA? There's a lot of literature and research out there on, talking to people about, and also done by applicants who have submitted MRTPAs. They have sometimes included those qualitative phases in either, developing their modified risk LLA, getting some initial qualitative responses to it, and also there's been cognitive testing of different items that ask people about what they think about products as well, to make sure that people are able to answer the questions in a way that would accurately reflect what they really think.
Actually move on to the next question. So in most studies of consumer understanding of modified risk, LLA, participants view the LLA as part of a controlled laboratory experiment, whereas in the real world, they would be exposed repeatedly and in various advertising formats. And so we're being asked to consider, would we expect the consumer understanding to differ between the real world and experimental settings? If so, how should we account for this in study designs? And what does our understanding in the real world look like? And how could CTP and applicants monitor consumer understanding as part of a post-market surveillance following an authorization?
Sure, I can kick us off. I think it is reasonable to expect that there will be differences. And this is the same thing if we think in terms of how we test messages, like smoking prevention messages, where we have experimental studies at the early stages, we see effects, and those are usually bigger effects. Then when we release the campaign in the real world, people see it, it gets messier. The effects are generally smaller. And there's a lot of literature on how to evaluate campaigns in real world versus in the lab and how to do that. And so just building up on all of that, and I would say measure the amount of exposure and see how that relates to the actual, how it's marketed. So like if it's only marketed very small, but you have a lot of exposure, where's it coming from? Or vice versa, if there's a lot of marketing happening, but people are not reporting exposure, what's happening here? And then how is this exposure relates to people who see very little, what's their beliefs, how does it differ with people who are really heavily exposed? Kind of CDC standard is like 12 exposures in like 4 months to see, okay, do we have that level of exposure in the real world and how that affects? And then very importantly, it would be good to also measure not just, this is called like the one-way flow, but there's also a two-step or two-way where not only do you get information from directly through this message, but you talk to people. You see other people maybe posting on social media, and so this needs to be taken into account, and this interpersonal conversations happening, that will change beliefs and perceptions as well. So accounting for that. And again, it's just, this is the way campaigns are evaluated in the real world, and the same approach could be used here for evaluating this real world impact of modified risk statements.
Yeah, I would say also along those lines, I mean, it really is about just doing broad surveillance. And so, for example, in the PATH study, just asking participants in PATH, just documenting just the general level of exposure to these types of messages that are out there, so that you have some context, right, from a generalizable sample versus a more kind of in-depth focus that you might see in a post-market surveillance study looking at consumers of those particular products. So, I mean, I agree with Lucy that you're going to get exposures that are going to be different in the real world. And so being able to monitor exposures in the real world, I think, is an additional ancillary piece that kind of needs to happen in a robust survey or surveillance sort of way. Mignon?
Yes, thank you so much. First of all, I'd like to applaud the FDA for considering this adaptive framework and for presenting these questions to our committee, because I think they're really important and could have tremendous implications for improving communications and messaging to the public. One of the things that I wanted to ask or delve a little bit deeper about before Scout did the mic drop and left was that I'm curious about specific populations, right? Because part of the issue that we have right now, and I don't think that this is a surprise, these are data that are published and we can see is an erosion of trust in various entities, you know, on the part of the consumers or the general public. And we see a greater erosion of trust and distrust for certain types of messaging it varies across different populations. And I'm thinking specifically within Black populations, because that's what I focus on. And part of this has to do with all of the sort of white noise and the other noise that's happening within the broader public related to messaging and hostility towards these populations or not, or perceived hostilities towards these populations coming from various entities. My question for you is, how can we account for or address this broader context? It's delving a little bit deeper to what Scout was saying, and I realize that it's slightly digressing from the typical conversations about, methods and things of that nature, but I'm really shifting more into the real world and how individuals consume information, but it is not it's not in a vacuum, right? They're bombarded with multiple types of information, yes, about these types of products that we're focusing on specifically, but we have to account for the broader context of the types of information that they're receiving more broadly that may be relevant or targeted towards specific populations. I hope that was clear. And if it was not, feel free to ask questions.
Does anyone have any additional, because we're starting to delve into things that we're now talking populations, and it's kind of hard to kind of isolate the thoughts around single discussion questions. So Olivia, did you have something to add to question 2? And if anyone else has something to add to question 2, then we'll move on to question 3. And then when we get to question 4, everything is open for discussion. But I want to make sure we get through the questions.
Want to piggyback on Lucy and Chris's comment about exposure measurement. I think it's important to measure exposure to these messages, and could also be relevant in real-world studies to measure these same consumers' exposure to other messages that might sort of conflict with what the message is saying, because that might ultimately also impact their perceptions. So whether it's exposure to tobacco prevention ads or campaigns or cessation messaging might also ultimately impact their perceptions.
Annette?
Just one last comment in terms of the question, and Olivia, as you were talking, it made me think that perhaps what is ultimately needed in addition to what's listed here is pre and post and continuity in the types of questions that are asked over time. So if an Mrtp is going to be released in January, the assessment of knowledge, understanding, perceptions, and all the other constructs that you want to get at must be addressed and assessed in the same population level that needs to carry pre and post release of the Mrtp claim or Mrtp.
Just to clarify, Annette, are you suggesting that before an Mrtp is made and the manufacturer can use it in their marketing materials, that there are some baseline measures that are obtained prior to that? Would that?
I think that would be ideal, right?
Yeah.
Because then you would be able to understand how the exposure in the real world, once the claim is out in the open in the real world, you would be able to track if any impact it is having at the population level.
Risa?
Thank you. In my mind, one of the differences between experiment and the real world is whether they actually read what you're providing them. So in an experiment, they're going to read it because you're asking them to read it, right? In the real world, if you give them a big, thick pamphlet, like comes with your medication, what's the chances that they actually read that? That's my comment.
Maria?
And also, I would like to hear your perspective, like how to really disentangle the comprehension of the claim, whether it's truthful, accurate, and not misleading, from the perception, which is influenced by many other factors. Like, we're talking about the preconceived notion of products that are not really less risky than conventional cigarettes. It's the peer pressure, it's the motivation of the individuals, it's the attitude and beliefs. How can we take these into account when we are talking about real-world situations? So maybe it's not the misperception of the claim as much as the internal beliefs of the individuals, which will impact how they will, explain the claim to themselves.
So in the context of those post-marketing surveillance studies, I think it would be a good recommendation for the manufacturers when they're designing their studies to include relevant covariates that are known to be associated with either uptake or quitting, so that they can be controlled for in the analyses. move on to question 3, but that doesn't mean that folks can't come back to 1 and 2. So as covered in the presentation, there may be some unique consumer understanding considerations for the intended and unintended users of an MRTP. Should consumer understandings be assessed differently for various populations, and what are possible red flags that indicate consumers are misled or not understanding, or how those red flags be measured? So I'm going to jump in there. So A, with regards to B, I mean, I think monitoring sales data and continue to monitoring brands that are being used by various populations and looking for upticks, unexpected upticks in initiation and adoption of certain products, and if they're for the right groups, I think makes a lot of sense. And then just a comment with regards to populations, you know, earlier on, and I understand the distinction between naive users, who are more often than not are youth, right, and then current users of tobacco, but I also want to remind folks that youth are also current users of tobacco, and so could potentially be audiences for some of these messages if, in fact, it helps move them down or risk continuing or quitting altogether. They're not mutually exclusive groups, and I think we have to remember that. Lucy.
I want to caution against measuring differently for different populations, because then you won't be able to compare directly and see, are we even further increasing our disparities if we have measures that cannot be comparable between the two. For red flags, I would say make sure we do qualitative research, because that's when a lot of stuff you never even thought about comes up, and the misperceptions that people have is really interesting, and you can just show them the message if they've never seen it. Start by just asking, what have you seen communicated about this product out there? And then you'll hear some things that they say which is not anywhere, but they come up with this information. Then when you show, they often misperceive. So that's a really, qualitative research is really valuable for identifying those misperceptions. And then later on, you can plug those in and do surveys, just standard stuff. And also make sure doing social media monitoring, because that's where discussions on Reddit in particular, on users, oftentimes some come up with there, and like on YouTube videos where they talk about how to make a product less risky, for example, or whatever, evading regulation or other things. So like social media is a good source of information on that.
Move on to question 4. So consumer and study participants bring with them pre-existing beliefs that affect how they interpret claim information and answer survey questions. For example, the majority of the public believes that smokeless tobacco products are equally as harmful or more harmful than cigarettes. How, if at all, should FDA take pre-existing beliefs into account when assessing and evaluating consumer understanding of proposed MRTP claims? Maria?
I think it can be a useful tool to really ask before you want to expose the consumers or participants in the study to questions that are pre-existing beliefs, because it can help you to put the actual data into the context. Is it because of the claim or because they have their pre-existing beliefs? The same is about believability. If people believe the claim, you might be seeing different kind of the understanding.
And also brought up by folks here today, methodological approaches, obtaining a baseline before the MRTP claims are out there in the wild would be an important thing and would help address I don't have a star of 6 on mine. Or, you know, as in Alex's presentation, split sample randomized experiments, right, where participants half see the MRTP claim and half that don't. And so, you know, even if you don't have baseline data, those that didn't see the MRTP claim can be used as a proxy for what some of those baseline beliefs might be. And so I think methodologically there's some approaches that can be used. Olivia?
Yeah, I agree with those comments that Chris just made. The only thing for a brief experimental study, I always consider not necessarily asking pre-existing beliefs before exposure to the claim, because you don't want to prime them or influence how they're going to answer the questions right after. But I think, you know, if you have that in the control group, then you have that proxy for it. And certainly in sort of the population level studies, you have a lot of time in between the assessments. So.
Recognizing that it's been a long day, I'm actually going to turn to FDA and ask, have you gotten some useful information from these 4 discussion questions, or shall we just keep trying to discuss?
We've conferred. Yes, no, this has been really, really helpful, insightful. You know, like you said, it has been a long day, but I think it's been a lot of the, you know, the sort of topics you guys are raising are things we've been considering ourselves. So it's helpful. I don't know, Alex or Aaron, if there's anything else specific you wanted to touch on.
Okay, I'll say one thing. So one thing, this wasn't necessarily really like the motivator for the question here, but I feel like one thing that maybe gets somewhat, or maybe got a little bit lost in the discussion for the related to consumer understanding for the Swedish Match application was just how surprised a lot of the U.S. public would probably be if they heard kind of the epidemiologists and the medical people who are, you know, medically trained and are able to view the epidemiological data. I know there's some disagreement about other things that maybe are not captured or the time frames of studies, but is it like, should we be looking at like how big is the gap between what the average potential user for the product thinks, or current user or dual user of a product thinks about its risks, and what someone who is an epidemiologist or another kind of specialty who focuses on tobacco research, what they think? And should that have some sway in kind of how much we think it could benefit someone, if we think there is this big gap, basically?
So you're talking about providers potentially as a population that you might want to follow up on, or did I misinterpret that?
Oh, not necessarily.
I mean, we've done a study showing people the IQOS ad with and without the MRTP claim, and the MRTP claim changed providers' willingness to endorse the use of the product to someone who smokes cigarettes who is not willing or able to quit, right? And so they're potentially, right, the population targets for some of these MRTP messages might extend beyond the consumers themselves, but is that what you're getting at, or no? I'm getting wrong.
I was getting more at, so presumably the modified risk information could seem to have like more potential to change what a consumer thinks, because they're already so far in one direction in terms of their perceptions of a product, and then what, say, an epidemiologist who has studied it extensively would say. And in the case where there is that really big gap, should we kind of, you know, give that should that influence kind of how we evaluate the MRTP, kind of the potential, because you might think there's more potential there for like long-term consumer benefit to having access to, clear information about how the product risks compare, or should that play a role in our evaluation, I guess?
So I'm not sure I understand your question, but let me try, which is that, so if, using this example, if we think that, if the public thinks that smokeless products are as bad as smoking cigarettes, but the MRTP claim is that they're less harmful than using smokeless, that a particular brand is less harmful than other smokeless tobacco products, so does it matter that they overestimate the harm of tobacco, of smokeless? Because as long as they think it's less than smokeless, then it's going to be less than cigarettes, even if they're incorrect about the cigarettes. So that's where I'm confused, what you're asking.
So I'm a visual person, so just bear with me. I picture basically like a bell curve of some kind, and if you've got people really far like in the negative, like they don't even have a neutral belief. They have a belief that smokeless is like equally or more harmful than cigarettes, and we're trying to see the effects of a claim that is so far outside their pre-existing conceptualization of what that product is like. Should we take that into account, and if so, how, when we are evaluating whether a level of understanding is adequate?
I see. So you would have a bigger job because you're going from a negative to an even more further along, I guess.
Yeah, the claim would have a harder job, but for us, we're mostly focused on just like what do we do in those situations? Yeah. How do we, if at all, take that into consideration?
Risa? Yeah, I'm wondering, is it possible to develop there's a continuum of risk, right? Or have you already articulated that continuum of risk, and is it possible to present the user with that continuum and have them say, what do you currently believe, and now what do you believe after the advertisement, and then report the delta. And then that delta becomes the outcome measure as opposed to the absolute where you want to bring them. And then you could at least see people moving along the continuum as a result of the advertisement.
Lucy? Oh, this goes back to my earlier point about the need to clearly conceptualize what are you talking about when you talk about understanding. Because this is you talking about persuasion and change in beliefs, which is different. And the one statement is likely not going to get you there. Multiple exposure to the statement might, but it needs to come from different sources. There's a lot more needs to be done. I mean, with tobacco persuading how harmful cigarettes are, we've been doing this for a long time, and we still, my argument is like we haven't, even though people always say like they're very harmful, but they still don't have that very deep understanding. And so in that sense, it might be worth do measure it in different ways. Do they understand it? Kind of like Alex was talking about. Is their understanding, is it comprehension? Do they understand what the statement says? Do they agree with it? Is a different story completely. And moving the agreement and belief is going to be probably not going to be as one exposure. And then another thing I wanted to point out is like we keep focusing on the modified risk communication, but it's really, we always measure in comparison to cigarettes, and so like emphasizing the risk of cigarettes, that might be another way of kind of reducing. So like it's not just two things, it's like you bring up the perception of cigarettes, even if perception of risk of smokeless stays here, you're going to have a bigger discrepancy. And so we could work in two directions, and measuring both should be useful, because we also don't want them to think like, oh, this is less harmful, but where does the perception of cigarettes go as a result?
Olivia? Yeah, I agree with all those comments, and especially the difference between sort of the understanding of it on its face and belief of it. I think we also just need to be thoughtful about like our expectation of the ability to change the belief, not only based on the number of exposures, but, you know, who the claim is coming from, and that impact on the believability of it, as well as the fact that they're seeing it with the warning label information, and that, you know, to some extent that might feel contradictory. Also, I was going to say earlier too that in terms of study designs, I think, you know, potentially including the use of some open-ended questions that could even follow up some closed-ended questions could also be another way of kind of understanding perceptions a little bit more in some cases. The issue with the switching completely kind of wording in claims, we talked a lot about that being a sort of difficult language and difficult to communicate, but it's also difficult to measure. To find the right measure for that, I think, is really challenging too, and I think the applicants, you know, have a first stab at it, but if FDA can provide guidance on good ways to do that as well, I think that will be helpful.
I think the suggestion for cognitive testing of the messages as well is super important, and not just of the messages, but then of the survey questions that are asking about the messages are going to be important, and having different population groups kind of captured in that, I think, is also important. We know that, you know, individuals who are receptive to harm reduction and switching often do quite a bit of research on their own before they, right? And so they tend to be more knowledgeable about the products, and then also less likely to have incorrect perceptions about the risks of the product and nicotine. And so they're, you know, you're preaching to the choir to that group, but then understanding and making sure that the other populations of interest also understand the questions, I think is important. Sven?
I think it's a specific challenge if consumers need to, have to compare two products where both have an MRTP, right? So, for example, how do they compare a very low nicotine cigarette now with general snus, right? Where both have claims they are healthier than, let's say, cigarettes, right? Because the VLN, you say you smoke less, but then you're probably less addicted. However, then with general snus, it has more nicotine. You probably will use it indefinitely, right? So I think there are specific challenges here that will be difficult to really overcome if consumers have to compare products where both have an MRTP.
All right, keeping an eye on the time. I'm not going to have us go round robin for final comments, but I am going to let anyone that hasn't yet spoken or feel that there's something additional that they want to say about these 4 discussion questions. I want to give everyone a chance to make a final comment. Yes.
I wanted to say something with respect to the first question, just in terms of consideration of potential additional characterization or contextualization. There was, just to piggyback on a previous comment, of reduced exposure, reduced risk, or the combination of the two. And when you have a product that has lower exposures to potentially harmful constituents, like what are those constituents? Are they carcinogens? And how does that compare to combustible cigarettes? And I'm from California, we have that language in our labeling in the state when we have products that contain carcinogens or reproductive or developmental toxicants to specify what the chemical is and what the hazard is. So some additional characterization or contextualization on exposure and what the potential risk is of that exposure might be helpful.
Annette. So I think a suggestion would be to keep it simple and keep your eye on what the goal is of the study or of what you need to know. And the questions need to map onto what information you need. So whether that is specifically knowledge or whether that is specifically risk perception, not couching that in being accurate or inaccurate. It is a perception, not knowledge. and also product harm. And product harm could be accurate or not accurate, depending on how you want to frame it. But assessing the questions that assess those things need to map onto what information FDA needs to make a decision.
Any final comments? Going once, going twice? I'd like to give FDA a chance to make any final comments before we adjourn the meeting.
Thanks, Chris. I just really want to thank everybody here today for sticking with us to the end. It's been a long day, but it's been a really productive one. You know, we've had a lot of fruitful discussion, both with regards to the Swedish Match renewal and the specific evidence presented there, but then also with regards to this broader conceptualization of how FDA has been thinking about consumer understanding. So just a big thank you to the committee for all your work here. Thanks to the applicant for the work that went into the preparation and your presentation. Big thank you to our CTP staff for all their work, the work that's already happened and will continue to happen around Mrtp. We appreciate the open public commenters and, of course, the attendees, both here in person and online. So, you know, we're really pleased that we were able to come together to have this meeting. As Brian mentioned, we haven't had a TPSAC meeting on Mrtp in quite a number of years. So it's really, we're excited that we're able to get back together. It's been really productive, and we look forward to just continuing to engage with the committee around these types of topics. So once again, thank you to everybody who participated, and safe travels home.
Thanks, Ben. I want to also thank the committee members, our consultants, Swedish Match for their presentation, the individuals making the comments during the open public hearing, FDA, and a special thanks to Serena and Janice for taking care of the committee. And with that, the meeting is adjourned.